this next topic may very well break the TikTok internet world, and it's the S word. So you guys need to help me in the comments, because I would say that here at my facility, our emergency medicine colleagues and our internal medicine hospitalist colleagues are probably the experts on managing this initially, whereas I'll get a call after the fact once we kind of already have a diagnosis. So say you have an acute appendicitis or a perforated diverticulitis, or someone super sick from a necrotizing soft tissue infection, say a neck fash, that's when we're getting the call. So again, my EM colleagues, I really want you guys to weigh in on this. So I can give you the medical school version and some definitions. So we'll start with SIRS. SIRS is the Systemic Inflammatory Response Syndrome, okay? And there's 4 different things, if you will. So it's heart rate greater than 90. And I find that kind of interesting because tachycardia technically is considered a heart rate over 100. But for SIRS criteria, we go with 90. Temperature. So it's either less than 36 degrees Celsius or greater than 38 degrees Celsius. And that's the same as 100.4 degrees Fahrenheit, or I think 96.8, I want to say, degrees Fahrenheit for that hypothermia side. So a patient's also then tachypnic. So there's a respiratory rate greater than 20. And again, guys, this isn't necessarily my area of complete expertise with the criteria, but I always would say too, if somebody was on the ventilator with acute hypoxic respiratory failure, that also counted. And then lastly, for SIRS, our white blood cell count, either less than 4,000 or greater than 12,000, okay? So now, SIRS then becomes sepsis when we have 2 of these, okay, plus a source, or a suspected source is what a textbook would say. So that's what then sepsis is considered. So this is, again, where I really want my emergency medicine colleagues and other specialties to chime in here, because we get what's called code sepsis in the emergency department all the time because patients meet this criteria and they have a suspected source. For me, that suspected source typically is in the abdomen, an intra-abdominal infection like what I mentioned before, so acute appendicitis, acute diverticulitis, different things like that. Or maybe it's in the chest, maybe it's a pneumonia. Again, maybe it's a soft tissue infection. Lots of different things here. So again, please, emergency medicine colleagues, help us at your different facility. What's triggering a sepsis alert at your institution? So then next we have severe sepsis, okay? Now we're getting into problems because we're experiencing end organ dysfunction because of the infection. So typically we'll say a lactic acid greater than 4 milliosmoles. And again, lactic acid means we're not perfusing, like we talked about in our shock lecture. So your end organ perfusion is not aerobic anymore, it's switching over to anaerobic, and you're getting a lactic acidosis. Altered mental status for neurologic. Cardiovascular, you could be getting demand ischemia now, and you could be having a myocardial infarction. And other acute kidney injury would be another good one. Acute kidney injury, respiratory failure. All these things are now severe because you're having end organ dysfunction. And then septic shock, finally. And we had our shock lecture, so now we're not perfusing at all, and you're requiring vasopressor support, okay? So my other question for my colleagues out there, because again, I'm seeing this after the fact. What are we doing when we get a sepsis alert? We're starting antibiotics, we're ordering blood cultures, we're bolusing the patient with crystalloid. And crystalloid, for those of you who don't know, that's normal saline lactated ringers, IV fluids. There's an appropriate amount that you're supposed to bolus the patient. And again, don't quote me, not my particular specialty, because again, in the ICU, when I'm taking care of surgical trauma burn patients, they all kind of have this criteria. And a lot of them in their shock state is multifactorial. So it becomes really difficult. And then what will happen is a resident or a student will write the word sepsis in a note in a chart. Then that gets abstracted by the abstractors, and then we sometimes have these sepsis fallouts. And that's why it's super important for our emergency medicine colleagues to catch this in the beginning, because it's going to decrease mortality. That's the whole reason why sepsis alerts kind of started in the first place. So again, this is the S word. It's going to drive a lot of, I think, comments. And I'm really curious to see what you guys are doing for this. And again, me as the surgeon, I'm kind of coming in after the fact or managing this in the ICU, but talk to me about that initial management.